Dear colleagues, welcome to today's EHRA webinar on catheter ablation of ventricular tachycardias in structural heart disease. My name is Josef Kautzner and I'm head of Department of Cardiology of Institute for Clinical and Experimental Medicine in Prague, Czech Republic. The aim of this webinar is to provide an overview of key characteristics of arrhythmogenic substrates for ventricular arrhythmias in ischemic and non-ischemic cardiomyopathy, and review the different approaches for catheter ablation, including epicardial and/or some alternative strategies like alcohol ablation, etc. We have two excellent speakers today. One is John Silberbauer from Sussex Cardiac Centre in Brighton in the UK. The other is Frédéric Sacher from Hôpital Haute-l'Évêque in Bordeaux, France. And I would like to remind you that this is a highly interactive session and strongly encourage you to actively participate by sending your questions or comments at any time during the webinar through the chat. I can then see it here and answer the MCQs that will be submitted during each presentation. And this EHRA webinar is possible thanks to unrestricted educational grant from Biosense Webster Johnson & Johnson Institute. Saying that, now I will hand over to our first presenter, John Silberbauer, and he will tell us about ablation in ischemic cardiomyopathy.
Thank you very much. So these are my disclosures. I'm going to illustrate, if you like, my approach and some of the decision-making required to undertake VT ablation in post-infarction patients through two case presentations. And this is case number one. So this is a 74-year-old gentleman who had previously undergone coronary artery bypass grafting in 2003. He then presents for the first time with sustained ventricular tachycardia recently, October 2017. He's then re-investigated, so he has an angiogram which shows that his grafts are still patent, so good result from previous surgery. The LAD is occluded. And the key, I think, preoperative investigation is the echo. So the echo shows, firstly, he has severe left ventricular dysfunction, and that's kind of a key point when going into a VT ablation. It's a marker of risk, for one thing. And secondly, we have two regional abnormalities, anteroapical and inferior. So they're signs of both an anterior and inferior myocardial infarction. Of course, this is potentially driving you to the location. So he has an ICD implanted and then shortly thereafter presents with effectively a storm, if you like. So he's having 10 episodes of treated ventricular tachycardia a day on amiodarone. It's all ATP, so we're not dealing with shocks, but nonetheless we felt that with this very high arrhythmia burden, it was entirely sensible to plan an endocardial VT ablation. Endocardial, one, because it's a first procedure, and two, because obviously he's had previous bypass surgery, potentially precluding epicardial access. So that's the background to the first case. Here we have his documented clinical ventricular tachycardia. So we have a right bundle branch block ventricular tachycardia, transitions around V4, so shouldn't necessarily be completely basal, and we have a left superior axis, so coming from the perhaps infraseptal side of an inferior infarct. So I guess if we're trying to put together the echo and the 12-lead ECG, this would be driving me towards his inferior myocardial infarction rather than the anterior myocardial infarction. We start our procedure by making a substrate map. So this is an example of looking at the anterior infarct. This has been made with a high-density mapping catheter, Pentaray. In this case, we have a few thousand points. Our particular way of making a substrate map, on the right, you'll see the voltage using standard cutoffs of 0.5 to 1.5 millivolts. We could discuss whether those are still appropriate in the era of high-density mapping catheters, but we still use those for ease. And then on the left, we have an activation map, and in particular, we've set it up so that late potentials are purple. So anything that's in purple is local electrograms that have been activated after the end of the surface QRS. Of course, that doesn't pick up other abnormal electrograms, so that's the reason for the manual tagging that you see. So the green potentials are fragmented potentials. So we go around and we make our substrate map in this way. Here we have the inferior infarct, and perhaps surprisingly, although there was akinesia on the echo, we see only patchy low bipolar voltage. I don't have it here, but when we looked at the unipolar, it was more extensive, possibly indicative of a deeper infarct. And then on the left, you see again that we have late potentials infralaterally, very tight to the mitral valve. So that's our substrate mapping effectively completed. One thing I'd like to point out is that when we look at the septum, and in particular the apical septum, because it's activated early, we're less likely to find late potentials in this particular location because it's harder to be late. And so here we typically have a lot of fragmented potentials, and that's exactly what you can see here with all the green dots that we've noted and is shown on the pentaray electrogram on the left. So here we can see it's fragmented, but it's actually still this bit's inside the QRS. This double potential here is inside the QRS. There's perhaps a little bit late there. When we look at the infralateral portion, we see here, if you follow this spline here of the pentaray in blue, we have the first lower frequency far field signal. So this is the normal activation of the infralateral wall. And then within the infarct, we see this late potential, which is higher frequency and is very late. And we're more likely to find late potentials in this location because this is the latest area of the ventricle to activate. So these are pretty expected findings, I would say, under the circumstances. We then, once we've completed our substrate map, moved to VT induction. As you can see, we've managed to induce the clinical ventricular tachycardia that I've shown you previously. The issue is, of course, that it's non-sustained. So what do we need? We need a sustained tachycardia and we need a tolerated tachycardia in order to do activation and entrainment mapping. So we don't have that in this scenario, so we have to find alternative approaches. And for us, this means moving to pace mapping to locate the area of interest. So here on the right, you see the pace map. We have a relatively short stimulus to QRS, and an excellent pace map to the clinical ventricular tachycardia. This means that we're relatively close to the exit site of the clinical ventricular tachycardia. At exactly the same location, you can see these nice late potentials here, and this for us is reason enough to, or evidence enough, to direct catheter ablation. And you can see here we are ablating at 45 watts, and we're trying to achieve forces in the region of 10 to 20 grams. If we see high forces, that will be a reason for us to withdraw the catheter for safety reasons and then reposition and start again. We're also making sure that we don't have any impedance rises. After we'd got rid of the clinical ventricular tachycardia, we then did another VT stim to see where we were in the procedure, and we induced this pulseless ventricular tachycardia. So here on the right, you can see it's got a superiorly directed axis. It's almost negatively concordant across the precordial leads, perhaps a small RS complex in V1 and V2. So this is an infraapical septal ventricular tachycardia coming from this location. We have a 90% pace map as shown by the correlation here, correlation map to that tachycardia there. Of course, that's not mappable because it's got no blood pressure. So this is going to be my first question to the audience. The clinical VT is clearly gone. We've demonstrated that. We've had good targets for ablation. Now we have a non-clinical pulseless VT that's induced. What, if anything, should we do next? So I guess from my perspective, options would include stopping. We have a great result. This patient was having 10 VTs a day. We've got rid of that VT. We can stop. We could alternatively target all the abnormal substrate that we've already identified through activation and voltage mapping and tagging of fragmented potentials. We could pace map to the exit of the fast VTs and then ablate the exit sites. We could do a very extensive scar-based ablation homogenization type procedure until we become non-inducible, slightly non-specific approach. Or perhaps we could call the ECMO team, or we could put an impeller in to make this pulseless VT mappable with a view to directing ablation there. So I'd be interested to hear what people think is the next step.
I have already some responses here. Maybe some more people would vote, maybe not. So the winner is number 2. Which is reasonable. I would say I would do the same. And the second one, most frequent, 22%, is number 3, which is also reasonable. But there are also 15% would call ECMO team, 12% would stop. So there are different responses.
Well, that's good. I mean, there's no right answer because we never know the future, of course, for a particular patient. But our strategy would be that we've made a substrate map, but we haven't actually directed ablation towards a substrate that we've identified yet. And I think most people would agree that the combination of substrate mapping and ablation plus having an idea of where the exit is through pace mapping would be the place to move on to. And that's what we did. So here we can see that we've done extensive ablation within the scar, about 45 minutes of RF. We've then remapped with the pentarray. And you can see here, this is an area that we missed with the original ablation. But here you have late potentials in the area. And then you can see a second set of ablation is delivered after remapping. And we did a bit more around the anterior portion of the scar as well. We then do another VT stimulation, and you can argue whether that was necessary to do at this point because we completed our substrate ablation, but we induced a new pulseless ventricular tachycardia. And it says final VT stim because we decided to stop at that point. From our perspective, we had a successful endocardial substrate modification as proven through remapping. We had non-inducibility of the clinical VT, which was clearly the problem that the patient came in with. We still had multiple pulseless non-clinical VTs that we could induce. We stopped because we'd already done an extensive ablation procedure and we were happy with what we'd done. And we also were dealing with a double infarct procedure, so it's perhaps higher risk with severe LV dysfunction to do more on the day without a clear target. The follow-up's been good. Do you think that was the right place to stop?
I think I would stop as well because you do substrate modification and then you do aggressive stimulation, you induce very fast VT that may not be clinical anymore. So there is not much to add at this stage. If there will be recurrences, you have to choose some other option, go epicardial, maybe with surgical help or do something else. But at this stage, I think it's very reasonable to stop.
Yeah, it's always a balance between the benefit and risk, obviously.
Because some people voted for hemodynamic support. I would personally have left that for clinical recurrence of VT. Would you?
Yeah,
exactly. If you don't have real substrate, we use it only in such cases. Let's continue.
Let's continue. So here we have another post-infarction patient. So this is a 60-year-old male who had an inferior myocardial infarction in 2004. He had a chronic total occlusion of the right coronary artery, which was not intervened on at that point. He then presented with VT 6 years later in 2010, and he underwent ICD implantation and endocardial VT ablation. He was fine for a few years, but then presented with predominantly exertional VT and some angina with shocks in 2015. He underwent opening of the CTO to the RCA, but had further VT, and we therefore listed him for an endoepicardial VT ablation based on the fact that he'd already had a previous endocardial ablation. That's probably indicative of potentially epicardial substrate. It depends a little bit on how that procedure was done, of course, but that would be our basic workflow. In Brighton, we have our own method of getting into the pericardium, which involves intentionally puncturing out a coronary vein and inflating some CO2 into the pericardial space, which gives a real space, if you like, for a subxiphoid puncture. I'll just show you how that works now. So this is an agilis in the LAO view sitting in the coronary sinus here. And then we have a a JR4 diagnostic into a lateral branch here, and then a microcatheter, so like telescoping, and then this wire is then puncturing out. Here you see it puncturing out into the pericardial space, so from the inside out. We can then push the microcatheter normally pretty easily over the wire into the pericardial space, and we've made a 2 French hole here in the lateral branch. Once we've done that, we can inflate the pericardium with CO2, perhaps 100 to 150 mils. And this is a lateral view, and you can see the needle coming in here. You see tenting of the pericardium, it's just gone through, and we can then access with a real space, which avoids the risk of RV puncture. That's the normal way we would do it, but things didn't go like that in this patient. So we came across an obstacle. And you can see here, if you look at the right-hand picture, you see these discs of dye. There's 1, 2, 3, and 4. This is 4 venous exits from the coronary venous system, where the wire and microcatheters not move freely in the pericardial space. And so we believe that we've diagnosed pericardial adhesions, and they appear to be quite globally distributed, hence trying to go in different locations. We therefore were stuck with an endocardial-only procedure. So here we have substrate mapping in the way that I've shown you before. So we have voltage mapping, 0.5 to 1.5 on the right, and we have an activation map on the left. The activation map is in sinus or pace rhythm, and everything that's in purple is after the end of the surface QRS. So what we have is a large infraseptal myocardial infarction with delayed potentials that are occurring after the QRS, basally adjacent to the inferior mitral valve annulus. We have 2 separate inductions, and we induce 2 ventricular tachycardias in this gentleman. The clinical VT, which has this right bundle branch block morphology, transitions between maybe V2 and V3, relatively negative here across the precordial leads. It's got a superior axis. So this is coming from inferior wall, and then perhaps slightly laterally. And then here we induce another ventricular tachycardia, which is clearly much faster and in fact was pulseless and nothing that we documented before in its defibrillator, which has a left bundle branch block morphology and a superiorly directed axis. So this will be coming from this sort of apical infraseptum. Potentially even exiting on the right. We were, of course, interested in the clinical ventricular tachycardia. It was tolerated and sustained, which meant we could do activation mapping. So we've done high-density activation mapping here on the left. And you have what I've termed pseudofocal, because you get the impression of focal activation of the left ventricle, perhaps a slightly wide area than you would in a normal focus, but it still has that same centrifugal activation. And it's pseudofocal because, of course, this is a reentrant arrhythmia, and we must be missing the reentrant circuit somewhere else. So for me, this pseudofocal exit's highly indicative of a deeper substrate. When you look at that with respect to the voltage map, it's actually outside the scar of the endocardium as well, and that's another key that we may be missing a deeper substrate. So that's, if you like, an unlucky start there. We have some pace mapping. We don't get great pace maps, but we get reasonable pace maps showing us that we are not too far from the exit. So this is 84%. And this directed an ablation towards both ventricular tachycardias and the substrate. So the rapid apical septal VT, we've ablated here on the LV and the RV side. It finally went with RV ablation at 60 watts, so that's quite high power. We did some ablation to the late potential areas adjacent to the mitral valve, and of course, the main thing we were trying to get rid of was the clinical ventricular tachycardia, which was exiting laterally outside the scar here. But despite high-power ablation, we were never able to suppress the tachycardia, and I guess that's another indicator that it was not endocardial, in addition to the things that I've already mentioned. So it was a failure. We left the patient with his clinical VT still running, an acute failure, and it was no surprise that the patient had an early recurrence of his clinical ventricular tachycardia. He may have had dense pericardial adhesions as assessed by an impossible coronary venous exit, something not validated. So my next question to the listeners is, what do you think is the next step for this patient? One, we could put him on long-term amiodarone. That may suppress his tachycardia. We could alternatively repeat more elegant endocardial mapping. Maybe we missed something to direct a more accurate ablation that might be effective. We could try a more aggressive endocardial ablation on the basis that getting to the epicardium is going to be tricky. We could attempt a standard subxiphoid epicardial access to allow epicardial ablation, or we could do a procedure with the surgeons where they get a limited thoracotomy and manually break up the adhesions to allow us to get access for ablation. So those were the thought processes at the time. Let's see what people think about what is the right thing to do next.
The bars are still moving, so some people are still voting. It's interesting to see the spectrum of responses. Some people would go for amiodarone. That's now 17%.
Okay.
12% would repeat more elegant endocardial mapping.
So sorry.
The winner is surgical thoracic access. It's actually 36%, and then the second one is attempt at standard subxiphoid epicardial access and ablation. So it's a reasonable answer, I think.
Yeah, so I think at least my thought process at the time was that the gentleman's 60 years old. He's otherwise pretty fit and healthy, apart from his inferior infarct. Do we want him to be on long-term amiodarone? What is the risk from that drug to him in the long term? It must pose some significant risk. I felt that the activation mapping showed a focal exit, and we probably hadn't missed anything. I didn't feel I was deliberately more aggressive than I would normally be to make this decision more easy, to avoid this business of do we go back and do an endocardial procedure. We believed there were adhesions, a standard subxiphoid access would fail, so therefore we took option 5. And so we know that the patient has an inferior myocardial infarction. Therefore, usually the surgeons through a subxiphoid access will be able to dissect the adhesions at least maybe back to the mitral valve if possible, perhaps slightly laterally. That will be the usual thing with dense adhesions. Perhaps you get lucky and you get further around. The adhesions were very dense in this gentleman, as we'd suspected. And you can see that this shows really quite a limited epicardial map. This is the only area we could get to. So here we have a voltage map. You can see that we are inside the inferior infarct. And we got lucky on this day because we got far enough here, sort of infralaterally, to identify abnormal potentials. As you can see here, that we've used the decanav rather than the pentaray at this location. We've now switched to the ablation catheter, and we have VT running, and we have mid-diastolic potentials in this area. The pace map is actually perfect with a longer stimulus to QRS, so we're at least some way back into the isthmus. So all these are good things for ablation. He's in atrial fibrillation, but we come on with RF, and you can see that the VT terminates, and the VT runs in and out for another minute or so, and it's never seen again. So we stopped the procedure at this point. The endpoints were that we achieved a non-clinical VT ablation using endocardial access. We achieved a clinical VT ablation on a second procedure using surgical access. We had a strongly negative VT stim from both ventricles. I wasn't sure about the fullness of the substrate ablation because, of course, we only saw a very limited area of the epicardial substrate, so that wasn't proven. But during follow-up, he's had no VT, and importantly, from my perspective, that's on bisoprolol rather than amiodarone. So I think, in conclusion, regarding post-infarction VT, there's usually a clear target, and that's obviously the infarct. Ablation of the clinical VT is the first goal. For secondary goals, we can try and make patients completely non-inducible, or we can achieve substrate ablation. And there are multiple studies from multiple centers showing that VT recurrence during follow-up is lower if you can achieve those secondary goals as well. So we at least aim for that, but we need to be realistic about how far we go to try and achieve those goals. Sometimes hemodynamic support and epicardial ablation are required, and the results are certainly better than in non-ischemic VT cases.
Thank you very much for a nice presentation. There are a couple of questions that would be addressed to you specifically. One of them is irrigation speed for 50-watt application.
So I normally increase the irrigation to 30 when I'm ablating at 50 or 60 watts, even if it's with a multi-hold catheter.
It's pretty high energy.
I know.
We believe, based on experience with POPs with higher energy, that this would be safer with a new generation of catheters like diamond tip, which we will now run the study with this technology. And it measures temperature from the tissue, so it allows you to safely deliver even 50 watts and without pop. So far the experience is very limited, but it seems to be safer than with conventional thermistor or thermocouple catheter.
Yeah, of course we don't want high volumes of fluid to be given to patients with heart failure, but it's exactly what you said, it's a safety issue. So our experience is that pops are lower with the higher flow rates, and we watch the impedance very carefully at high power.
Yeah.
And there was also...
I think this is another thing, so watch out the impedance change and
exactly.
increase.
Yeah.
If it goes more than 10-15% down, you should stop, because then you have imminent pop. And there was also a question, if you can again explain your strategy to inflate pericardial sac, how to do it safely, because people probably missed that detail.
Yeah, so the idea is to create a real space in the pericardium, and one way of doing that is to put a gas in the pericardium. The gas is compressible, you're less likely to cause tamponade than you would with the fluid. But how do you get it there, obviously? So one way of getting it there is to intentionally make a small hole in the coronary venous system, put a microcatheter out, which is 2 French, put the CO2 in. If you're lying on your back, the CO2 will come to the top. Mm-hmm. That allows an anterior puncture. The method we've developed is published in the paper, or feel free to contact me if you want more details about it. But in brief, we are having an agilis in the coronary sinus. A diagnostic catheter subselects a branch, like doing CRT. We then have a wire down the branch, a stiff wire, and a microcatheter, which normally easily perforates out. It's for people doing CRT. There's not really any new steps.
There is a question immediately. It comes to your head whether it's bleeding when you use maybe endocardial approach with heparin. So.
Yeah. So our approach would be, that's a very good question. Of course, if you make a small hole in a vein, you do have some bleeding. In nearly 100 cases, we've never had one case of serious bleeding, and a lot of those cases have been anticoagulated with heparin or NOAC, warfarin.
So is it important to be very distal in the vein, or even pretty proximal is okay?
We try to be distal just because it seems to make sense that if you're going to make a hole, make it in a smaller vessel.
Okay. I guess I have one more question. In your experience, is it frequent to get adherences in the absence of previous cardiac surgery, as in your case, or? No,
that's a good question. I think in the absence of previous cardiac surgery, 2 or 3% precluding access. However, when mapping, you often find small adhesions that you can feel on the catheter breaking through.
But I noticed that the patient had a LV lead
Yeah.
So might have some relevance because it may cause some inflammation. So that might be explanation. Or we saw some cases where you have a really old aneurysm with calcification. There might be adhesion also,
Yes.
quite big adhesion.
A few cases like that are patients with prior major pericarditis or those patients with huge infarction, pre-rupture, actually with huge aneurysm. And in those patients, you can have some adhesion, but otherwise it's pretty rare.
Maybe there was a second pathology in this case.
Yeah.
I think we have still time for questions at the end of this webinar. So now we move on, and I would like to invite Frederick to give us some talk about the difference in arrhythmia substrate in non-ischemic cardiomyopathy, which is obviously more complicated and a broader spectrum than in post-MI. So, Frederick.
Thank you very much, Joseph. So yeah, my talk is to talk about VT ablation in non-ischemic cardiomyopathy patients. So as said just earlier, ischemic cardiomyopathy patient is pretty frequent, and it's a more common indication for VT ablation. But VT ablation in patients with non-ischemic cardiomyopathy is increasing, as you can see in this study, with a proportion of patients with non-ischemic increasing compared to ischemic, even though ischemic cardiomyopathy patient remains the first procedure, the first indication. And I think this is the first question, and it's a multiple choice question. So what are, according to you, are the particularities of VT in non-ischemic cardiomyopathy patient? First, epicardial origin is more frequent compared to ischemic cardiomyopathy. You have more frequently bundle branch reentry VT. You have a lower success rate of VT ablation. You have better tolerated VT. And there is always a clear substrate identified on the voltage map in non-ischemic cardiomyopathy patients.
So there are questions here, and I have some answers already. Maybe we allow more time for people, because there are still probably very few.
Don't worry, we'll discuss all these possibilities afterwards. It was just to start with.
So far, the leading answer is a lower success rate of ablation.
So yeah, they listened to the previous presentation. That's a good point, at least.
At least, yes. Some people believe, 30% believe that more frequent epicardial origin, which was also discussed a little bit in the first
that's
case.
True too.
Bundle branch reentry, 19%.
Okay, which is true also.
2% believe that you can always have clear substrate. Which
unfortunately
is
not.
Not, and also 9% believe that it's better tolerated, or 10%.
There's no reason either for that too. So I guess the three true answers were 1, 2, and 3. More frequent epicardial origin compared to ischemic. It has been said earlier, even though you can have some epicardial origin in ischemic cardiomyopathy, especially in inferior myocardial infarction. Bundle branch reentry VT, we'll discuss that a little bit later. And lower success rate, yes, of course, depending on the substrate. So the thing is, as said, it is becoming more and more frequent. It's a second etiology, even though it's not one etiology. It's a very heterogeneous group of substrate, and this is the first point and the most important. You have to know what is the underlying substrate when you go for non-ischemic VT ablation. It can be purely idiopathic. It can be valvular heart disease, myocarditis, Chagas, laminopathy, prior myocarditis, or sometimes you don't have any substrate. What has been described in the literature is that it's mainly basal scar, but once again it depends on the underlying substrate. And epicardial ablation have been demonstrated in the literature up to 25% of the cases of VT ablation in non-ischemic cardiomyopathy patients. So it's very important to get imaging, cardiac imaging, before going for ablation, and we systematically perform MRI, cardiac MRI, before ICD implantation in our patient for two reasons. first to get an idea of the underlying etiology, and sometimes if you identify sarcoidosis or this kind of thing, then you can treat directly the pathology and not just the symptoms afterwards, which VT is. It's just a symptom. It's not the cause of the non-ischemic cardiomyopathy. And second, if they start to get VT and you have to go for ablation, then you have an idea of the substrate, where it is, and how to plan and what will be your strategy for the VT ablation. Here is two examples there. On the left panel, as you can see, we have left ventricle here with delayed enhancement. There, subepicardial delayed enhancement and preserved endocardium. If you go endocardial, just endocardial, you have no chance to get rid of the substrate and get rid of the VT. And in this particular case, you have to plan to directly go epicardial. In this other case, it's pretty different. You see, the delayed enhancement here is mid-myocardial, intraseptal, so no need to go for epicardial access, but then plan other strategy, and you will understand why you may not have a very demonstrated voltage map, and sometimes you will have to switch for other tools to get rid of VTs coming from this area. But once again, it's very important to know it before, because it will be much helpful during the procedure. Other kind of imaging have been described, such as CT scan, and you can note wall thinning on CT scan that can help to localize the substrate. And now there are some LED contrast sequences that can almost give the same kind of information as delayed enhancement on MRI. So the CT scan is becoming more and more interesting to identify the underlying substrate in non-ischemic cardiomyopathy. Other tools is the ECG, the basic ECG. So if you are lucky enough to get a 12-lead ECG of the morphology, there are some criteria that has been described to help identifying an epicardial origin from Antonio Berrezzo in Barcelona, but also from the group of Frank Marczynski at UPenn. This works pretty well in non-ischemic cardiomyopathy, but probably not for ischemic cardiomyopathy, and neither for right ventricular VT. Those criteria are probably not working in the other situation, just for left-sided non-ischemic cardiomyopathy. So once you have started your procedure, I think even if we are the area of substrate mapping, it's important to induce VT, still try to identify the mechanism. These are all papers I could find in the literature, and in at least 2/3 of the case they had reentrant scar-related reentrant VT, but you can have some focal VT and some bundle branch reentry VT. In my experience, reentrant VT, when you have a scar, are much more frequent, and focal VT are more frequent when you cannot find any scar, even on imaging pre-ablation. And I would say, in my experience, bundle branch reentry VT occurs to 5 to 10% of the case, specifically if you get some conduction disorders and dilated cardiomyopathy. So these settings, in these settings, you have to particularly pay attention to this kind of VT, because if you go just for substrate ablation, you will not be able to get rid of the bundle branch reentry VT, and it's too bad, because if you recognize it, it's pretty easy to ablate. Anyway, so the workup we are following for VT ablation is getting venous access, arterial pressure line, because those are sick patients, so you want to monitor the arterial pressure line. If we plan to go epicardial because we think it's epicardial, we are going straight after that to epicardial access before any transeptal or any anticoagulation. And then we do the voltage map, the epicardial voltage map. It let us 20-30 minutes to do the map, tagging the abnormal potentials, the local abnormal ventricular activities, so-called LAVA. And like that, you can see if it bleeds or not. If it's not bleeding, then you can go endocardial with full anticoagulation, transeptal or retrograde aortic, depending on your strategy, and then do your endocardial voltage map, tagging again all the abnormal local ventricular activities. one little thing is the unipolar map. So if you did your endocardial map, you didn't plan to go epi and you are just endocardial, and you have a completely normal voltage map, then you can switch to unipolar voltage. It takes 2 seconds, and it can give you an idea of the transmurality of the lesion, of the scar, sorry, or what happens on the epicardial side of the wall. So it's very easy, it takes very little time, and this can be helpful to, if you cannot find any substrate, to know whether there's something you just cannot see with your bipolar mapping. Then, once we get our map, voltage map, we use a diagnostic catheter on the ETH before induction to be able to record the ETH and to rule out this bundle branch reentry VT. And with the ablation catheter or the high density mapping catheter in the area of scar to be ready to map if the VT is not so well tolerated, at least having 10, 20, 30 seconds to map in the area of potential interest. If the VT is stable enough, then we try to map it with a mix of activation, entrainment mapping, and eventually ablation if we think we are at the right spot. One thing, it's important not to stay in VT too long, and the mapping time in VT should be inversely the duration of the mapping time in VT is inversely proportional to the ejection fraction. Lower is the ejection fraction, shorter should be the time in VT, because after you have a risk, even if the pressure is good, if it lasts for too long, you have a risk of problems and cardiac dissociation afterwards, or cardiogenic shock. Then, once we get the VT, then we go for the substrate ablation, as said earlier, for the ischemic cardiomyopathy, we're tagging all these lavas. And if the VT is not tolerated or unstable or non-inducible, sometimes it happens, then we go for ablation in sinus rhythm or paced rhythm, depending on the mapping you did, targeting all these abnormal signals and trying to get rid of these signals. And the endpoint is really elimination of the abnormal signals, as in this case. You can see there some high frequency signal and lower frequency signal, and during ablation it split, it became late during ablation, and then it disappears, exactly like when you do PVI with a lasso in, you will see the signal disappearing during ablation. And this is really the goal, not just to put a red tag on an area, but really getting rid of the abnormal potential there. And then when we think we eliminate all this abnormal activity, we often remap to be sure we didn't miss anything, and then we test inducibility again. If it's non-inducible, we stop, and then otherwise we are targeting the VT, and then it depends on the cycle length, if it's tolerate or not, and how the patient is going. So 3 examples of non-ischemic cardiomyopathy VT: myocarditis sequela, valvular cardiomyopathy, and intraseptal scar, which is probably the most difficult case for VT ablation. Here is an example of a patient with prior myocarditis a few years ago. You see on MRI that the disease delayed enhancement, subepicardial, maybe transmural there. So we imported the MRI images, and he had CT too, in a model, in a mesh model, using a software we developed, the music software. And you can have there the scar, as you can see there, with the coronary venous system, coronary artery system, with the coronary arteries in red there, and then in green the phrenic nerve. We imported that in our 3D system mapping here, as you can see, and then we did the voltage map, and then we induced the VT, as said earlier. And you see we are in VT, we mapped, and actually I'm just on the spot, so we did entrainment, the return cycle was perfect, so I was about to ablate just there, but if you look carefully, there is a branch of the artery. They're just on my catheter. So for once, I wonder whether the merge was good or not. I hoped it was not so good, but I did coronary angiography, and unfortunately it was very good. Actually, I was just pushing on the artery, so I had to move my catheter away from this excellent site for the ablation. Second, valvular cardiomyopathy. There are several papers in the literature, and the scar on the substrate is often perivalvular area because there is a lot of remodeling around the valve when there have been valve change and mechanical valve, and most of the time it's around this valve, so it's important to know, not always, but often. And finally, the intraseptal scar, which once again are probably the most difficult to get. In the theory of UPenn, it was present in 12% of their non-ischemic cardiomyopathy patient cases. 1/4 had complete AV block. Just keep in mind, if you had AV block and VT, there are two things you have to rule out: is sarcoidosis and laminopathy. There may be other diagnoses, but they are the two main you have to rule out, at least. And you see in this case, the bipolar voltage did not show anything, and he has to switch to unipolar, and then it became much more obvious that this septum was not normal, and it showed there on the MRI. The reason why it's not so effective is that the lesions are not most of the time not transmural. You are very pleased when you can reach 5 mm depth with the RF ablation, and the septum is much thicker than that, so it's sometimes difficult, and most of the time difficult to get transmural. So here is a case of a patient with this intramural scar. It's pretty frequent to have limited bipolar low voltage area. If I had switched for unipolar, it would have been much bigger area. But then in this case, so RV, LV, you don't have much substrate, so you have to target the VT. And you often end up with LV, RV ablation, a lot of ablation both sides, and not being so much effective. In this case, we also went in the coronary sinus, and as you see, it was not so bad, minus 40 milliseconds or 40 milliseconds ahead of the QRS, but was still not enough. And despite ablation there, the VT was still inducible. So what would be your next steps, or the one or two next steps? So please, so epicardial ablation, would you go for epicardial ablation? Would you go for bipolar ablation? Would you go for transcoronary ethanol ablation? Would you go for surgical ablation, or just let him have recurrent VTs because you don't have any other option? So is it?
Not yet.
Not yet.
Not yet.
Okay.
We have still some remaining time.
Okay.
A few seconds.
Yeah. Of course, he was already under amiodarone and all the antiarrhythmic drugs you could have.
39% for bipolar ablation, 27% for epicardial, which in this location is probably not the best choice.
So as you see, we went coronary sinus, so you don't expect with true epicardial to do more than what you have done with with this coronary sinus. Plus, it is pretty basal, so there is a lot of structures that are not so pretty dangerous to ablate on.
So bipolar or transcoronary ethanol?
Sounds completely reasonable. Yep. So for those who are not very aware of bipolar ablation, is, as you know, at present time when we ablate, we are delivering the energy through the distal tip of the ablation catheter toward the back pad. And bipolar ablation is delivering between, with a small box, you can connect two ablation catheter, and you will deliver the energy from the distal tip to one catheter to the distal tip of the other. So the idea is to position two catheters both sides of the septum or any structure facing each other, stable, and then delivering between the two. Like that, you can be transmural and have a better local efficacy of the lesion. This is what we have done in this case with the two-view RAO-LAO view. See, we are facing each other. So right now, we at that time, I mean, we had to do that with just fluoroscopy. Now they are developing, Biosense is developing a box to be able to see those catheters in the 3D mapping system. And then, if not successful, then you can do transcoronary ethanol ablation. It's a long story, and has been performed even before the area of modern electrophysiology. But this is something that the interventionists know very well, because it's the same kind of things that was done for hypertrophic cardiomyopathy. So this is what we did. This is the angioplasty guide wire. We connected to the EP system, and we could record the signals, which was minus 50 milliseconds, and it was by giving alcohol in this area, we managed to get rid of the VT. So basically the way we did was to put a guide wire, then we put an over-the-wire balloon, inflate the balloon, inject cold saline, and if the VT stop with the cold saline, then we apply with the balloon inflated, of course, alcohol up to 5 millimeter with the balloon once again inflated to be sure there's no backflow in the coronary artery system. So to conclude, ladies and gentlemen, the pre-procedural timing in patients with non-ischemic cardiomyopathy is particularly important to know the underlying substrate, the area of interest, and to plan whether you have to go EP or not. Once you get the VT, try to elucidate the VT mechanism, especially if there is dilated cardiomyopathy, a long HV interval, rule out bundle branch rotary VT, and then there is kind of specific substrate. It's not a unique substrate, it's non-ischemic cardiomyopathy patient, and depending on the substrate, the strategy will be different. Thank you very much.
Thank you, Frederic, for a nice presentation, very well documented. If I can add something, I will have a few slides from my side, if we can have this presentation. Okay, so there are different strategies, as you heard from both presentations, and they are all complementary. So you have to know all of these, and you can integrate them. That's what we call integrated approach. Both speakers did not mention the other option, which is intracardiac echo, which allows you to have online imaging. So you see a scar clearly here, intramyocardial scar. You see how surface inside the left ventricle could be uneven with different trabeculations. So mapping with any multipolar catheter could be difficult. This is right ventricle in cardiomyopathy, right ventricle arrhythmogenic. This is POP. You see the blast here. So, or you can see also thrombus, calcified thrombus. So these are all options. And there are different strategies of substrate modification, and you heard about alternative strategies. We mentioned alcohol or bipolar ablation. We should also mention percutaneous support. This is impella in the left ventricle, and for this fast VT, which was not very sick patient, but we couldn't identify, despite the modification of substrate, we couldn't identify the target for this tachycardia, but only when we were able to map and do entrainment, we identified the spot where we terminated tachycardia. And also another strategy which is developing now, there were a few publications already, which is called radiosurgery. So you irradiate the area of substrate either with photons or protons, like this cyberknife case with a big tumor, fibroma associated with several different tachycardias. Some of them were ablated surgically or through catheters, and one of them was ablated with this radiosurgery. So these are all options today. So we have a big armamentarium, and we have a lot of strategies. There are many questions, obviously. One question which I found very interesting is there any diagnosis where you go straight ahead epicardial without thinking?
Yeah, of course. We didn't mention all the different kind of substrate, but once again, imaging is very important. Apart from the imaging, if you have a Brugada syndrome, for example, and you think you have to go to do ablation to these guys, you know that you will have to go epicardial. If you have myocarditis sequelae, it will be epicardial. Chagas, I don't have personal experience on Chagas disease, but it has been described to be epicardial. The question is probably RVC. Personally, we go straight epicardial, even though in some time you can get it from the endocardium, but I find from epicardial side, you better identify the substrate, and it's easier to recognize the VT circuit if you have an epicardial mapping, especially at the beginning of the disease. So this is our routine practice to go epicardial in those kind of cases. And then if once again the images, either MRI or other thing, even with CT scan, there are some late contrast sequences which has been developed that can tell you almost as much much information as did in an MRI, and if it shows that it's more epicardial, then I would go straight epicardial. One thing for epicardial, I think it's important to get used to it, to do a certain number, to get trained, and to get a surgical backup in case something is going wrong for this case. So.
John, if you have only ICD recording, not a 12-lead ECG, what do you do, how you approach this case?
So I think if a patient was having paroxysmal shocks, then I would be very likely to do an induction awake at the start of the VT ablation procedure to see if we could at least document the VT before going under general anesthesia. If the patient's having frequent VT, then I'd be less concerned about it because they're very likely to be inducible even under general anesthesia. So that's my approach to dealing with ICD documented VT. Obviously, you can then match it up with the cycle length.
Cycle length, yes.
But I really like to have at least something to pace map against, particularly if I'm worried about a case where the substrate may not be clear, such as in a non-ischemic case.
Or maybe on the reverse, having a huge substrate, a huge anterior MI, and then you may end up with not the full substrate elimination. Yeah.
Any experience with sarcoidosis patients?
Yeah, this is not so easy. So I think that's an important point to recognize it. A long time ago, we had a case we did not recognize. It was diagnosed as RVC, and we missed the corticosteroids phase. And that's too bad, because if you recognize it, and then if it's the active phase of the disease, then more than VT ablation, it's important to get the dedicated specific treatment, which is corticosteroids and methotrexate or whatever, depending on what the internet think it is. But it's important to recognize the substrate and treat the cause and not just the symptoms, which is the VT. Because once you are the chronic phase, then it's often patchy area, sometimes pretty hard. And in the different series, half of this patient referred for VT ablation go to cardiac transplant anyway.
There's also a question whether you can do VT ablation in conscious sedation. That's what we do generally. We use general anesthesia only for epicardial cases or some complex cases when the patient is already intubated, or VF ablation, but not for a typical elective case. But everybody does it in different ways, so all options are possible.
Yeah, definitely.
There are some questions about hybrid imaging. I don't know what hybrid imaging means, but I assume that it's probably merged with different strategies of imaging.
Yeah, I think this is important because you showed us echo also, which is intracardiac echo, and I think any piece of information is interesting to have for those complicated cases, because anything can help. So for us, we have been able to use CT, MRI, or actually any kind of images, and to implement that in any of the 3D system we have. And once again, it helps us to determine the substrate for efficacy, but also for safety if we are epicardial, for the phrenic, for the coronary arteries, or these kind of things. So this is pretty helpful.
So what catheters you use for this high-density mapping? If you showed nice cases of high-density mapping.
I mean, obviously the cases I showed today were done with Carter, so we were using the Pentaray, and in fact we used the Decanav, but normally I would use the Pentaray. But it depends which system we're using. So
I think we can say there is high-density mapping catheter for any system dedicated, which are pretty good. Any of the system
HD grade
HD grade for velocity and the Orion for arrhythmia, and they're all good, different but all good, I think.
Well, then what do you consider indication 1A for ablation?
I guess it depends on though I mean there are some it depends on the substrate though. I think it's different in ischemic and non-ischemic patient. And not saying 1A, but I will have a lower threshold for ablation, for VT ablation in ischemic cardiomyopathy patient compared to non-ischemic.
Or if it's incessant, or if it's storm.
Yeah, of course. But in general, I will have a lower threshold to go for ablation in ischemic cardiomyopathy patient versus non-ischemic.
I'm afraid we are approaching the end of the webinar, so we have to close this session. I would like to remind you some key messages for your daily practice. You learn that there are differences between ischemic and non-ischemic cardiomyopathy. They reflect different arrhythmia substrates and mechanisms possibly. And especially in non-ischemic cardiomyopathies, you have to expect epicardial approach or septal location of scar with some additional alternative approaches. Also, we have to emphasize that ablation in structural heart disease requires special expertise. We discussed that many approaches. You need really expert center for this. Not everybody who does ablation of pulmonary veins should do this. And saying that, I would like to thank both speakers here because that was an excellent job. I would like also to thank again Biosense Webster Johnson & Johnson Institute for supporting this webinar. And you will be able to see again this webinar offline in few days on the website of ESC. Thank you very much.
Thank you.
And have a nice evening.
Thank you.